Stroke is a leading cause of long-term disability and death worldwide. With advances in acute care and rehabilitation, more people are surviving strokes, but many face ongoing challenges. Not only do survivors deal with physical limitations, but they also experience emotional and psychological hurdles. Among these, post-stroke depression (PSD) is a significant concern, impacting recovery and quality of life. Understanding the factors that influence long-term outcomes after stroke is crucial for patients, families, and healthcare providers. This video explores how proactive depression screening can change the trajectory for stroke survivors, offering hope for better recovery and improved well-being. Post-stroke depression is a common yet often overlooked complication following a stroke. Studies show that PSD can occur in both ischemic and hemorrhagic stroke survivors, with episodes that may be brief but frequently recur over many years. The presence of depression after stroke is linked to higher mortality, greater disability, and reduced participation in rehabilitation. Despite its impact, PSD is sometimes missed in routine care, leaving patients without the support they need. Recognizing and addressing this hidden burden is essential for comprehensive stroke recovery and for improving long-term outcomes. To address the challenges of post-stroke depression, a hospital in Singapore launched the Effective Mood Management After Stroke (EMMAS) program. EMMAS is a clinical service designed to proactively screen all stroke patients for depression at multiple points during their recovery, early in admission, before discharge, and at outpatient follow-up. The program uses validated tools like the Hospital Anxiety and Depression Scale (HADS) and the Patient Health Questionnaire (PHQ-9) to identify patients at risk. If depression is detected, timely interventions such as psychotherapy or medication are coordinated. This integrated approach aims to provide holistic care and support for every stroke survivor. EMMAS program involves a team of trained health professionals who screen patients for depression using the HADS and PHQ-9 scales. Screening occurs at 3 key times: within the first week of rehabilitation admission before discharge and at the first outpatient follow-up. Patients who screen positive are quickly connected to appropriate care, which may include weekly psychotherapy sessions, medication, or both. The program excludes patients under 21, those medically unfit for screening, and non-residents. All data are carefully recorded for ongoing research and quality improvement, ensuring that the program evolves to meet patient needs. Evaluate the impact of EMMAS. Researchers conducted a cross-sectional case control study. They compared two groups of stroke patients, those treated before EMMAS was implemented and those who received care under the EMMAS program. Both groups were matched on key factors like age, gender, stroke type, and severity using a method called propensity score matching. This approach helps ensure that any differences in outcomes are likely due to the program itself, not other variables. The main outcome measured was a composite of death, institutionalization, need for a full-time caregiver, or depression more than 5 years after stroke. Study included 493 stroke patients, 366 who participated in the EMMAS program and 127 from before its implementation. Patients were eligible if they were 21 or older, had a confirmed stroke diagnosis, and could communicate in English, Mandarin, or Malay. Those with severe communication difficulties or who could not provide consent were excluded. The groups were carefully matched to ensure comparability. Demographic data showed an average age of 62.7 years with a mix of stroke types and risk factors. This diverse sample reflects the real-world population of stroke survivors in Singapore. Results were striking. After matching, patients in the EMMAS group had significantly lower odds of experiencing poor long-term outcomes compared to those in the control group. Specifically, the odds of death, institutionalization, needing a full-time caregiver, or depression were about 3 times lower for those who received routine depression screening and intervention. This suggests that integrating mental health care into stroke rehabilitation can have a profound impact on recovery and quality of life. The findings held true even after accounting for missing data and potential biases. Study strengths include comprehensive data collection and a representative sample from a major rehabilitation center. The use of real-world clinical data and robust statistical methods adds credibility to the findings. However, there were limitations. Recruitment bias was possible, and some important variables like pre-existing depression or antidepressant use could not be included for all patients. Additionally, the lack of long-term follow-up data for some participants may have influenced results. Despite these challenges, the evidence strongly supports the value of routine depression screening in stroke care. Conclusion is clear. Routine and hospital screening and early intervention for post-stroke depression can improve long-term outcomes for stroke survivors, regardless of whether they are diagnosed with depression. This integrated model of care offers hope for better recovery, reduced disability, and enhanced quality of life. As healthcare systems consider adopting such programs, further research on cost-effectiveness will be important. Ultimately, addressing both the physical and emotional needs of stroke survivors is key to helping them rebuild their lives and thrive after stroke.